Welcome to Clinical Capsules from TRC Healthcare, your go-to podcast for fast, evidence-based insights. On this episode, Assistant Editor and Clinical Pharmacist Rachel Cole unpacks the updated recommendations for H. pylori management in an excerpt from our popular Pharmacy Essential Updates webinar series. TRC has been a trusted resource for healthcare professionals for over 40 years, and now we're bringing that expertise straight to your ears every second and fourth Tuesday in bite-sized, actionable episodes, right here on Clinical Capsules. With that, let's get started.
So let's begin by discussing some of the updated guidance for the treatment of H. pylori, an infection in the stomach that can cause ulcers. And like our article says, you'll see a shift in the treatment of H. pylori infections based on recent guidelines from the American College of Gastroenterology. So what is H. pylori? Helicobacter pylori is a gram-negative spiral-shaped bacterium that colonizes the gastric mucosa or the stomach lining and has adapted to survive in this very acidic environment. It's found in somewhere between 30 to 40% of the U.S. population and is a known cause of gastric and duodenal ulcers and a risk factor for gastric cancer. When it comes to H. pylori treatment, we're probably most familiar with the clarithromycin-based triple therapy, which includes clarithromycin, a proton pump inhibitor or PPI like omeprazole, and amoxicillin or metronidazole. And even though rising resistance to this regimen has been reported for years, it continues to be the most prescribed regimen for H. pylori in the U.S. And because resistance continues to be a concern for these antibiotics, the meds that are recommended to treat H. pylori are shifting to help increase eradication rates or get rid of the infection more effectively. For example, in some areas, antibiotics such as clarithromycin, metronidazole, and levofloxacin can see resistance rates of about 30 to 40%. In fact, H. pylori regimens containing clarithromycin or levofloxacin are now only preferred if susceptibility is proven or there's a high local eradication rate. So new guidance is shifting focus to optimized quadruple therapy, and all treatment regimens are now recommended for 14 days instead of 7 to 10. Another regimen we may be familiar with is concomitant quadruple therapy, but because it also contains clarithromycin, it's now only recommended if susceptibility to clarithromycin is known or suspected. This is also not a good choice for patients who've taken clarithromycin or any other macrolide, so optimized bismuth quadruple therapy, or BQT, is preferred for those with prior macrolide exposure or who have a true penicillin allergy. In treatment-naive patients, optimized bismuth quadruple therapy is recommended in patients treated without knowing prior antibiotic exposure or who have a true penicillin allergy. Regimens that include the antibiotic Rifutin now have a role as first-line options in some cases, like Rifutin triple therapy, available in a combo pack called Talicia, or the newer gastric acid suppressing med, vonoprazan or Voquezna. So let's dig into each of them separately to get a better understanding of these. So let's start with what exactly is optimized BQT and how is it different from regular BQT? Optimized means we're either increasing a dose and or the frequency of some of these components and a duration of 14 days instead of 10. Optimized BQT includes bismuth dosed at 300 milligrams 4 times daily, at least, metronidazole 1.5 to 2 grams daily in 3 or 4 divided doses, tetracycline 500 milligrams 4 times daily, and a twice-daily standard dose PPI for preferably 14 days. In practice, some common modifications are substitution of tetracycline with doxycycline, because tetracycline is expensive and may be out of stock, and a lower dose of metronidazole. But both modifications may be associated with lower treatment success rates. So we can usually recommend bismuth quadruple therapy first for treating H. pylori, which uses 4 drugs, a PPI, bismuth, tetracycline, and metronidazole. especially for patients with a true penicillin allergy, since it doesn't contain amoxicillin, or in patients who've used a macrolide in the past. Since it also doesn't contain clarithromycin, that's because prior macrolide use could increase the risk of clarithromycin resistance, which is one of the main reasons those clarithromycin-based therapies have fallen out of favor. So, regimens besides BQT may be needed in some cases due to issues such as cost, depending on what insurance we're dealing with or lack of, allergies, a pill burden, or med availability. There are two regimens that contain the newer acid-blocking drug vonoprazan or Voquezna dual and triple packs, and a regimen containing the antibiotic Rifutin may be another option. And there are pros and cons to each regimen, so let's walk through these. Now, the Rifutin triple therapy, or Talicia, contains the PPI omeprazole and two antibiotics, amoxicillin and Rifutin. So it's a triple therapy treatment for H. pylori in one capsule. Each capsule contains 10 milligrams omeprazole, 250 milligrams amoxicillin, and 12.5 milligrams of Rifutin. And the patient would take 4 capsules 3 times daily. But with this Rifutin-based triple therapy, you'll hear Rifutin has minimal resistance, which is under 5%, which is much less than macrolides like clarithromycin or metronidazole or levofloxacin. And I think for many of us, when we hear Rifutin, our mind immediately thinks about rifamycin-type interactions, and that is something to be aware of with Rifutin triple therapy or Talicia. Even though it's just used for 14 days, we do want to watch for interactions, since Rifutin's an inducer of cytochrome P450-3A4 enzymes. One key example is that Talicia can lower levels of most hormonal contraceptives. So we want to stay alert for patients taking an oral contraceptive or using the patch, ring, or an implant. And advise using backup contraception during treatment and for 28 days after, since the effect can last after the Rifutin is stopped. Also be aware of some unique side effects with Rifutin and let patients know about these. For example, Rifutin can cause GI upset, can turn body fluids like tears and urine brown-orange, and can permanently stain soft contact lenses. Okay, so we've covered our Rifutin triple therapy. Now let's look at the regimens with the potassium competitive acid blocker, vonoprazan. If we look at what these combo products contain, the Voquezna dual pack contains 2 meds, vonoprazan 20 milligrams and amoxicillin 500 milligram capsules. The Voquezna triple pack contains 3 meds, so the same ingredients as the dual pack, vonoprazan 20 milligram tabs and amoxicillin 500 milligram caps, but also adds on clarithromycin 500 milligram tabs. And the dosing schedule is also a bit different between the two. So what is a pharmacological consideration when prescribing the Voquezna triple pack? Well, because it contains clarithromycin, it's only suggested in the instance of proven antibiotic sensitivity because of the high resistance rates. So if we summarize some of our options here, with Rifutin or Talicia triple therapy, it's dosed as 4 capsules per dose, 3 times daily with food, which could be challenging for patients. Plus, it costs about $840 without insurance for a 14-day course. PCAB dual and triple packs, or Voquezna, carry a similar price tag to the Rifutin triple therapy. PCAB dual is the least complex, and the PCAB triple contains clarithromycin and may meet some significant resistance. Bismuth quadruple therapy can be a good option, especially in patients with a true penicillin allergy who must avoid amoxicillin, or in patients who've previously used a macrolide since it doesn't have clarithromycin and resistance is a concern. Bismuth quadruple therapy costs about $530 for a 14-day course, but may be more like $80 when substituting doxycycline for tetracycline, but some data suggest lower eradication rates with that switch. And again, some components are dosed 4 times daily. And bismuth may be poorly tolerated. For example, it can cause constipation. So, because there's a multitude of options and considerations for each treatment option, it's important to use shared decision making, taking into consideration patient specific factors, considering cost, adherence, interactions, and side effects. So, let's bottom line this since this has been a lot to take in. So, optimized BQT is recommended in treatment naive or treatment experienced patients when antibiotic susceptibility is unknown or the patient has a true penicillin allergy. Consider substituting doxycycline for tetracycline in BQT if cost is a barrier for optimized BQT. Consider PCAB dual therapy, which is our vonoprazan and amoxicillin, in treatment-naive patients having difficulty managing BQT. And avoid regimens with clarithromycin or levofloxacin unless susceptibility is confirmed. Now let's talk through some adherence tips so patients have the best chance of successful adherence and eradication of the H. pylori infection. Engage with the patient and family, if possible, to help with complex regimens using phone call reminders, pill boxes, and smartphone apps. Schedule the regimen. Talk to the patient about starting the regimen when they feel they'll have the most success. For example, if a patient has a vacation or a business trip scheduled in the near future, perhaps starting the regimen after returning home would be more practical. Let's review some practice pearls. So, PPIs are considered equally effective, so an equivalent dose of an alternate PPI can be used if needed. Proactively educate the patient of side effects of their specific regimen, and always be alert for allergies, and especially penicillin allergies, since many of these regimens contain amoxicillin. It's important to stay alert for use as directed SIGs on combo products and check e-prescription notes for any other directions to include on the prescription label. For example, patients getting rifabutin triple therapy or Talicia will take 4 capsules every 8 hours for 14 days. Patients getting Voquezna dual pack will take 1 vonoprazan tablet twice daily plus 2 amoxicillin capsules 3 times a day for 14 days. But those on Voquezna triple pack will take 1 vonoprazan tab, 2 amoxicillin capsules, and 1 clarithromycin tab twice daily for 14 days. Watch for any missing information on prescriptions for H. pylori, since multiple meds with sometimes complex directions can lead to errors. Since costs can vary widely, help the patient work through any concerns and substitutions, and engage with patients to help with adherence. Double check quantities, review days supply, and don't override drug interactions. And FYI, there's a combo pack known as Pylori, which has the components for BQT, but provides only 10 days of therapy instead of the recommended 14 days. So this is a big topic to digest, and the treatment options may seem overwhelming. Fortunately, find our updated FAQ, H. pylori from diagnosis to eradication, on our webpage, and also see our new H. pylori treatment summary that contains the information from the table in the article with some additional details.
We hope you enjoyed and gained practical insights from listening to this episode. We've linked the resources we mentioned and more on today's topic right in the show notes. Those links will take you straight to Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insights, where you'll find even more concise, evidence-based tools. If you're not yet a subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. And as a listener, you can save 10% on a new subscription with code CC1025 at checkout. Have a question or a topic suggestion? Reach out using the Send Us a Text link in the show notes, or email contact@trchealthcare.com. We love hearing from you. Thanks for listening. Stay sharp, stay current, and we'll catch you next time on Clinical Capsules.